All right. On behalf of the Rural Health Association of Utah, I'd like to welcome everybody out to our May 2026 RHAU Rural Resource Webinar Series. This is our monthly series where we highlight practical tools and programs that rural healthcare providers across Utah may not be familiar with the goal of strengthening our health outcomes and access in rural Utah. You can access recordings and materials for this session as well as all of our past sessions on our website, rhau.org/RHAU-webinar-series. We continue to build a comprehensive on-demand library tailored to the needs of rural Utahns and healthcare organizations across the state. Thank you for joining today and participating. It's your participation and viewing of these workshops and seminars that make it worth our effort. We're very excited for today's session. The agenda is as follows. We'll be featuring two programs today that are making significant impacts in the state and across the country, really, with Canary Speech. We're excited to hear first from Pam Chapman and Cassie Cowden, who will share information about the Healthy Environments Active Living, or HEAL program out of Utah DHHS and some of the initiatives they're working on. And following their presentation, we'll hear from Henry O'Conley and the Canary Speech team. And Canary Speech is an innovative Utah-based technology company. And Henry will be discussing the real-time voice biomarker screening designed to support mental health and neurological condition detection, which is some awesome content. I'm really excited for Henry's presentation. We're going to start with the HEAL program. I'm pleased to introduce Pam Chapman. Pam is a registered dietitian and certified diabetes care and education specialist. She's worked in the field for over 25 years, and Pam is a chronic disease coordinator at the Utah Department of Health and Human Services. She works to advance care and coverage for those impacted by diabetes and pre-diabetes in Utah. She serves as a state quality specialist for both DSMES and the national DPP and works with multiple partners throughout the state. Her duties include breaking down barriers related to access to care in diabetes and cardiovascular disease. Pam has a passion for helping people make changes that last a lifetime and live an active, healthy lifestyle. Joining Pam is Cassie Cowden. Cassie is a cardiovascular health specialist for the Utah Department of Health and Human Services. She leads statewide efforts to improve hypertension control through CDC-funded initiatives, including advancing self-measured blood pressure monitoring, or SMBP, tied to clinical support. Cassie works closely with local health departments, clinics, and community partners to develop practical workflows, policy tools, and referral pathways that strengthen the connection between community resources and clinical care. She's currently chair of Utah's SMBP work group and supports the Utah Million Hearts Learning Collaborative. Pam and Cassie, the time is now yours, and we'll go to 12:25.
All right, thanks so much, and thanks for the invitation for us to be able to present. You can go to the next slide. This is just a really brief overview of our program, the Healthy Environment Active Living within DHHS. We focus on diabetes, cardiovascular health. We also work with school health, school nursing, physical activity, farmers markets, Eat Well Utah, and efforts to promote breastfeeding with our early child care. I'll jump into my topic with the next slide. So just want to give a really quick, we don't have a lot of time, but to talk about a little bit about diabetes in Utah. Overall, Utah has a lower rates than the general public, but what I want to highlight is although 8.7% of Utah adults have diabetes and the national average is roughly around 9%, we do know that it's higher in our rural and frontier areas, up to 10%. It's also higher in those with certain ethnicities, such as Black, American Indian, Pacific Islander. They have higher rates, but not just when we look at ethnicity, but we also want to look at those with only a high school education have higher rates of diabetes, and we know that diabetes increases with age. And it is important to highlight that rural areas do have a higher concentration of older adults, so kind of keeping that in mind. As of 2020, Utah aged 65 and older represented about 21.7% of the state's rural population, compared to only 14.9% of the urban population. So we know that our diabetes rates are going up nationally and then going up as we age. And when we put all that together, it can kind of make for increased healthcare costs. Next slide. So when we look at this as a cost in Utah, $1.6 billion impact to Utah, we know that some of this is direct medical costs, such as the 1.3 billion, and then about 500 million is lost related to indirect costs, such as lost productivity. We also know that people with diabetes have higher medical expenses, something really important to consider. So we want to go at this with two different ways. The first one would be prevention. How can we prevent people from getting diabetes, especially those at highest risk? So the first thing I want to talk to you all about is the National Diabetes Prevention Program. This is a program that provides an entire year of support for someone at risk for prediabetes or someone already diagnosed with prediabetes. It includes 16 weeks of intense visits, so meeting weekly as a group, and then that moves on to every other month, every month throughout those last 6 months. So someone gets an entire year of support, and this is evidence-based. Our goals are pretty not huge. We're not asking anybody to go run a marathon and lose 100 pounds. We know that if someone can lose 5 to 7% of their weight, increase their physical activity to about 150 minutes per week, and participate in our regular weigh-ins and program, someone can decrease their risk of developing type 2 diabetes by 58%. For those ages 60 and older, this actually increases to about a 70% reduction. So this is an evidence-based program. Next slide. And we found that even though after some people did regain, as just typically happens with any lifestyle change program, we knew that after 10 years, we still have a 34% lower risk of developing type 2 diabetes. So a significant impact. The original study was done back in like 1996. So you got to wonder, okay, how does that data still holding? So if we go to the next slide, we can see that there is a potential savings of about $160,000 of savings per case of diabetes prevented with this program. This is a group class held in person or virtually. Some are also remote learning. But people are able to connect with peers and talk about how to make sustainable lifestyle changes, improvements in eating out, eating in, how to stay active, how to start being physically active if you haven't been physically active in your life, how to deal with stress, how sleep impacts your life. So those are all the types of things that are covered in the National DPP. Next slide. So how can you find more information about this program? You can go to our website, which is here, and you will, I'm assuming, get a copy of these slides from Casey. And we have a list of resources on our website, including a list of all those that are providing this program. Some programs do take insurance, such as Intermountain Health and the U of U. They have programs that are statewide, and Intermountain's classes are all virtual. So even if you're living in a rural area, you can attend those programs, and they can take care of billing insurance providers. Specifically, Medicare will cover this program at no cost, and it is considered a prevention benefit, which is not very common in the Medicare world to have a prevention benefit. Next slide. You can also register directly on our website for some of our programs. So that's the bottom half of this slide is just a screenshot of what it looks like on our website. You can sign up for classes that are currently going on. So anything from our outside providers to the University of Utah, you can register online, or you can reach out directly to Intermountain Health. I kind of mentioned this. So Intermountain is now offering both Spanish and English, and all of their programs are online. The University of Utah has partnered with Noom, if you've heard of them. They are a telehealth provider, and you can do this what they call asynchronously, or someone can take the program kind of on their own time, and you can register with that through the University of Utah. And then the University of Utah also offers their own in-person classes. So these are our big partners. You can also start your own program. So small areas, this is a great way to partner with a community organization to provide your own national diabetes prevention program. You can help meet the needs of your community. You can help your community members meet where they're most comfortable. whether that's at a local church or a local community organizations. Oftentimes people just feel more comfortable that way. And we can provide the coaching support. We can provide scholarships to become a provider of the National DPP. We can walk you through step-by-step how to provide this program, but it can make a big difference. Some of my favorite quotes from one of my participants when I taught this program, he told me that he won Christmas for the first time. Previously in his life, he usually gained 20 to 25 pounds due to inactivity and increased eating between October and January. This was a really rough time for him. And this particular year when he was taking the program, he lost 2 pounds in that period. And that is a huge success. He got off that cycle of gaining weight every holiday season. That's a small thing. Or people will tell me, I don't have to hold my breath when I tie my shoes because it's hard to bend over. There are small steps that can make a big impact on someone's life. The second part of our efforts is something called DSMES. And I know when you read my bio, there was lots of letters and acronyms. This stands for Diabetes Self-Management Education and Support. This is an evidence-based program to help those with diabetes. It is evidence-based. We can have lower A1C or lower blood sugar levels. We can prevent complications and improve quality of life. Unfortunately, we have a very low uptake of this nationally with those privately insured and insured with Medicare. On average, less than 6.8% of people get this service, but it's covered by insurance. It's actually mandated that it has to be covered by all public and private insurance for this. Generally, what happens, someone gets a referral from their provider to say that they need this, and they get 10 hours of diabetes education in the first year and then 2 hours each year after. So this can take burdens off providers of having to provide all that education in those 15-minute provider visits. And your patients then you can push your efforts to helping them with their other chronic problems and not have to worry as much about their diabetes. Diabetes educators will send that information back to the provider. They're not trying to take over care. They're just trying to empower that person to make more educated decisions about their life. Everything from chronic complications to medications and understanding medications, what to eat, how to adjust insulin if needed, how to deal with sick days, what to do when blood sugars are low. Those are all of the things that a DSMES program can provide. We also on our website have a list of all the DSMES providers on our website where you can just go on there and find the closest one to you. We also have a generic referral form because this program, unlike the National DPP, does require a provider's order. This can be a podiatrist. Someone who is treating the patient has to be the ordering provider. And this is just a screenshot. There are more programs than here. This was just a quick screenshot. I do want to highlight, this is especially for the rural areas, is a program that we work with called Above Diabetes. They're actually based out of a rural area in Vernal, and they are a virtual diabetes DSMES program. So they take insurance, they have dietitians, nurse practitioners that will work with the patients virtually. So this can take away that challenge of transportation and how to get there. They will work with people over the phone or over Zoom, and they can also take care of billing out to insurance. So basically all you have to do is refer the patient, and then Above Diabetes will take care of the rest. They will then send a note back to the provider of what's going on and what they've been educated on. Their programs have resulted in a 10% weight loss, improved time in range, which is improved blood sugar in the proper range, decrease in A1C, and increased patient engagement. Lastly, I just want to highlight this program called, you probably heard of USU Extension, but 2 dietitians have created a fantastic program called the Diabetes Cook-Along Series. This is where some people are at. Maybe they're not ready to take a DSMES program, but you know that they want to get some diabetes education. The cost is only $10 to $25. It's usually done by a dietitian, and it's 4 weeks where on video, in person, either one, depending on the area, someone can watch a cooking demonstration, cook a low-cost meal, and learn about diabetes at the same time. And so just my last slide is opportunities for partnerships. If you're interested in working more with diabetes, you can see my email is on all 3 of these work groups. Cassie's on the 3rd one. I'm on the first 2. The Utah Diabetes Coalition, we meet every other month. We bring in partners. This upcoming month, we'll be talking about oral health. We're going to have someone come and talk about retinopathy and AI. So it's a great way to work with other educators. And then the last one is the chronic kidney disease work group, where just in the name, we're working to address chronic kidney disease and improving that connection between diagnosis and screening. And that's my last slide. I'll let Cassie go.
Great, thanks, Pam. So I'm just going to walk through more of the heart health focus on our chronic disease team. So my presentation is focusing on self-measured blood pressure, or SMBP, which basically just means people checking their blood pressure outside of a clinical setting, usually at home. And this presentation is really focused on what it takes to support that beyond the clinic itself, especially around access, community partnerships, and referral pathways. So if you could please go to the next slide. So when we started this work, we kept running into the same challenges over and over. The first was visibility gaps. From a data standpoint, we rely a lot on BRFSS. The most recent data we have is from 2023, and it's just physician-diagnosed high blood pressure. It only captures people who have already been diagnosed. It doesn't tell us who's controlled versus uncontrolled. And like I mentioned, it's from 2023, so it's not real-time data. At the same time, nationally, it's estimated that about half of adults with high blood pressure do not have it under control, and they don't even know that they have it. So this visibility gap exists where people don't know there's an issue until they're already experiencing complications or in crisis. The second challenge is funding realities. We are funded under our CDC cardiovascular health grant, and we cannot use those funds to purchase blood pressure monitors for the community. So access completely depends on local funding, grants, donations, and partnerships, which means access is going to look very different depending on where someone lives. And then the third challenge is infrastructure. Clinics do use lending libraries already. It's not a new idea, but those programs can be difficult to sustain long-term, just with tracking devices, replacing lost monitors, calibrating them, maintaining staff capacity. So a lot of clinics are not maintaining those programs over time. So there hasn't really been a clearly defined system for what happens after someone is told to monitor their blood pressure at home if the clinic doesn't have a program in place. Where do they get a validated device? Where do readings get reviewed? And how do those readings actually connect back to care? So that's the gap that we're trying to address. Next slide, please. So just to give a little context on how this work is structured, I mentioned before, it sits under our CDC-funded cardiovascular health grant. Within that, we have the Utah Million Hearts Coalition, which brings together local health departments, healthcare systems, community organizations, and other partners focused on hypertension prevention and control. The SMBP work group is one part of that coalition and includes both state and local partners working on access to blood pressure monitoring outside of traditional healthcare settings. Next slide, please. And this is just a little more information about the SMBP work group itself. I'm the chair of this work group. My co-chair is Megan from a local health department. So she helps gap the two perspectives between our work. I'm really focused on the grant reporting and the systems level, where she's actually doing the on-the-ground work and seeing these implementation barriers in real time. So we're working together on that. Next slide, please. So when we started building this network, we looked into Libraries with Heart. This is a program through the American Heart Association where blood pressure monitors are placed in public libraries for people to check out and use at home. It's a very simple model, but it addresses one of the biggest barriers that we kept hearing about, which is access to a validated device. And libraries are important because they're one of the few community spaces that are consistently accessible across both urban and rural areas. So early on, one of the challenges was that many of these local health departments didn't even know that these sites already existed, so they couldn't promote it to the clinics they're working with or the community members they're working with. And at the same time, several local health departments were independently building their own lending libraries through grants and local partnerships. So there was multiple systems developing at once, but they weren't coordinated. So within this last year, we started working more closely with the American Heart Association and local health departments to align everything and create a shared statewide network. Next slide, please. So this map on the screen is actually started by Jamie Anderson at Southwest Utah Public Health Department. She had created her own internal map to track lending library locations in her region because there wasn't an official statewide system for tracking them. Shannon, she's our epidemiologist and evaluator here at the state. She then worked with Jamie to expand this into a statewide version, which you now see on the screen. This map combines lending library locations with age-adjusted blood pressure prevalence data. So the lighter areas are around 22%, darker areas closer to 33%, more in the rural regions. So this map helped us identify areas with higher burden and where areas access gaps exist. So it became a really useful tool for planning, but it wasn't something that clinics could easily use during patient care. So it didn't fully solve the referral side of that problem. Next slide, please. So from there, we moved towards creating this interactive map. The goal was something that would actually function as a real-time referral tool. So instead of just visualizing locations, clinics can now use this during a patient visit and so show someone exactly where the closest lending library location is. So this makes the process much more actionable and much easier to connect back to clinical care. So this is just a screenshot from the map on our website. We have two different symbols. The yellow hearts are libraries with heart sites, and then the blue circles are other lending libraries that were started from local health departments. And as of now, we have 122 locations across the state. And we're continually updating the map as new sites are added or information changes. So for rural communities especially, this helps create visibility around resources that people didn't know existed before. Next slide, please. And we can skip this slide. So this is when we started thinking about SMBP tied to clinical support, because now we've created the access to validated devices, but we didn't have a clear definition from the CDC or other states on exactly what this process was to make sure that it's all connected. So we broke this down into 5 steps. Very simply, the clinic recommends SMBP, the patient accesses a validated device, there's a clear follow-up plan, the readings are reviewed, and then action is taken if needed. And that last step is really the key piece, because if readings are never reviewed or acted on, then monitoring alone doesn't actually improve outcomes. Next slide, please. So once we had the map and a clear idea of what this process should look like, the next question became what resources people actually need to make this sustainable. And that's the phase we're working on now. We just launched the interactive map within the last month, and now we're working within the work group to create these 4 toolkit pieces that you can see on the screen and our work group meetings where we check in at the bottom. There's already a lot of strong SMBP resources that exist through organizations like the American Heart Association and CoMagine. So we're not trying to recreate anything from scratch. We're just trying to simplify and adapt those materials into something that feels more practical and easier to implement at the local level. So the goal is really to create a more plug-and-play structure for public health staff, clinics, libraries, and community organizations that want to support SMBP access. Next slide, please. So I can pause here. This is the QR code to explore the map and see the lending library locations across the state. Hopefully this helps illustrate what community-based blood pressure monitoring can look like when healthcare and community organizations are working together to support patients between visits. Thank you.
Excellent. Well, we have about 5 minutes here. We can open up for questions. I just want to say thank you to Cassie and Pam. These programs are great. Thank you for clearly showing how to access the programs, how to refer to the patient programs, and how providers can get involved. This is very, very helpful. there any questions from the group? Again, if you're watching the recording, Pam and Cassie would be happy to answer your questions via email. You can see their email addresses there on the screen. So reach out anytime. If there are no further questions, we'll just thank Pam and Cassie again. Our team at RHAU has been learning more about HEAL over the past few years, and we've been fortunate to be able to interact with them a little bit and support them, and appreciate the work they're doing in diabetes care and heart health across rural Utah. These are areas we can definitely make some improvements as a state, and your presentations definitely did a great job of showing the resources and steps that our healthcare professionals in the association can take to help their communities that are in need. We encourage you again to explore the resources through the links and share those with your team, and then connect with Pam and Cassie and the HEAL team if you have any additional questions. We will switch gears now and hear from Henry O'Connell. Henry is the CEO and co-founder of Canary Speech, a leading AI health tech company using real-time vocal biomarkers to screen for mental health and neurological conditions. With over 2 decades of experience in technology leadership, including roles at Hewlett-Packard, Gilson, and NIHL, Henry has served on the boards of multiple tech companies globally. A passionate advocate for voice technology in healthcare, O'Connell regularly speaks on the transformative potential of AI and voice biomarkers to improve disease detection, patient monitoring, and clinical decision making. Henry, the time is yours.
Thank you so much. It's really a pleasure to be here today and to be with you. And I look forward to whatever questions we may be asked, and anything that you have a question about, don't hesitate to ask it or to put it in the text. Canary Speech is 10 years old. It was founded here in Provo, Utah, by myself and Jeff Adams. Jeff Adams, my business partner and dear friend, was born here in Provo and graduated from Brigham Young University before going on to get graduate degrees in mathematics. Jeff and I met 40 years ago. I was at the National Institutes of Health as a researcher in neurological diseases, and Jeff had a much cooler job than I did. He was at the NSA, where he was building mathematical models to de-encrypt spy messages. We actually listen to conversational speech. Please go on. So Canary Speech is truly advancing this field. I don't remember if later I mention it, but we have 23 issued and 17 pending patents in this space. We truly were the tip of the spear. But it was not new to Jeff. Jeff had led the team that built Dragon Naturally Speaking. He led the team that built the Amazon Echo. So he had extensive experience in the field. I had spent my entire life after NIH in the medical area. We got together because we were friends all that time and we wanted to do something together. But Canary Speech uses vocal biomarkers to assess conversational speech for a range of different diseases. And we do that in an ambient listening mode, which allows us in real time to provide objective, actionable information to a clinical team concerning the treatment of a patient. We're classified as a clinical decision support tool. Please go on. Voice is the most complex motor function that we have. We actually look at, later in the slide set, it says 2,548 features. Today, we actually look at 2,590 different features in speech. Those features represent how the central nervous system interacts with the articulatory system to create language. Every 40 seconds, we are processing 15.5 million data elements, a very complex, large data set. And then we correlate that data set to a range of different diseases, working with clinical teams in different parts of the world, South America, North America, Japan, Europe. And that's allowed us to build algorithms that can, in real time, create accurate, objective information about a whole range of different diseases. And we screen for those during a conversation between a doctor and a patient. Please go on. I mentioned already that voice is the most complex motor function we have. The number of features we look at actually has increased since we originally created the slide. But think of it for a moment. When we're interacting with family members, or a nurse is interacting with a patient, a doctor is interacting with a patient, we often sense something is going on with the patient. That same observation drove Jeff and I to explore whether or not that sensing was not, in fact, our brain, our machine learning tool, capturing information in real time about an individual from an unspoken string of features that create language. Then we use machine learning and AI to create an entire solution that would allow us to, in a practical, simple way, put a tool in the hand of any clinical team member, either in a phone or on a tablet or over video conferencing or even on a telephone. Please go on. So in a very simple way, while we're listening to the conversation, not about anything other than how their day is, the conversation that a doctor or a nurse is having with a patient doesn't have to be about a specific illness or a disease. We don't pay any attention at all to the words that are being spoken. We're listening to sub-language elements. Those elements are evidence of a range of different diseases. Today, we look at diseases in the area of progressive neurological, things like Parkinson's, MS, and Huntington's. We're looking at anxiety, depression. We're adding postpartum depression and suicide ideation to that, as well as PTS. And we're also looking at mild cognitive impairment and Alzheimer's disease. So, and there are a few more. We're building autism and ADHD and behavioral health for children right now. We're looking at COPD to add to this portfolio, or the tablet of information and diseases that we can assess in real time. One of the magical things about the technology is each of those diseases has a clinically developed, clinically validated, peer-reviewed algorithm that assesses these 2,590 features in real time and returns scores while the doctor and the patient, or the clinical team member and the patient, are still in conversation, providing information, objective information, that can direct the next question, that could identify a potential illness that had not become apparent yet. And on that 40 seconds of audio, any of the diseases I mentioned, or all of them, could be measured at the same time. And the clinical team decides, what are we measuring in this particular engagement or interaction? Please go on. This can be so critical when one considers that often our patients are remote. We can connect through video conferencing, through Zoom, through Teams, through Teledoc, with patients in their own home. Caregivers that go to homes can bring a tablet with them, and these same assessments can be conducted there. This provides for an opportunity to enhance and enrich the objective information upon which we're making clinical decisions, and to do that seamlessly and non-intrusively. Because of ambient listening capabilities, we're not asking the patient to talk about anything specific. We're not asking the doctor or the nurse to ask any specific questions. We're just listening in an informed consent, in a high trust, HIPAA compliant tool. We're listening to their conversation, and in near real time, within seconds, we're providing that caregiver with information for any of the diseases I mentioned. Please go on. So Canary Speech today partners with a range of of industry standards, Microsoft, Teladoc, Zoom for healthcare. We're partnered with some of the AI enhanced technologies such as Avashar, Artisight, HelloCare, bringing intelligence into the space where patient and clinician or patient and clinical team member are engaging to enhance the information that they have for making decisions. No additional tools are needed, just the conversation. Some capturing device like a smartphone or integrated into a Dragon Copilot that's doing clinical notes and clinical documentation. It allows for early detection of many of these diseases. MCI and Alzheimer's are terrible diseases. The sooner we know that our patient has them, the sooner we can begin planning their care and helping their family engage in planning their life. It's seamless. It's integrated seamlessly. I like to say non-intrusively, because we don't ask for anything. We just listen. And it's scalable across populations. The non-invasive nature of it makes it comfortable to work with. Please go on. So you can see the use of the product across the entire spectrum or continuum of care. You can do this in wellness. We have wellness assessments as well. Behavioral Health Month, May is Behavioral Health Month. We launched a free app. People can use that for measuring anonymously and in a data secure HIPAA compliant system. They can measure their wellness. In primary care and community care centers, we can use this in urgent care, acute care. When individuals are visiting our families at home, this enriches that experience for them. And in chronic illness and chronic diseases, this allows for the tracking of those and a longitudinal picture of how the patient is doing over time. It's objective, it's scalable. It happens almost seamlessly. In 40 seconds of conversation, we're picking up 12 seconds here and 10 seconds here and 5 seconds here of the patient, and then we process that in real time. Please go on. We have a number of diseases. I've mentioned almost all of them, but anxiety and stress and depression and mood. We also, in our wellness app, measure energy levels and fatigue. We measure mild cognitive impairment, Huntington's disease, Parkinson's disease. We also have an app that measures aggression levels. This has been deployed in hospitals where our nursing staff are experiencing violence in nursing rooms. What we do is we just monitor the audio in a room with a partner like HelloCare, and we're capable of providing for the room a risk level for aggression, and then providing a green, yellow, red light warning on that room. Alzheimer's disease is something that is a horrible illness. Most people self-diagnose, frankly. A spouse gets a call from a grocery store. Their husband or their wife has been going there, the same place for the last 25 years. And on this particular day, they can't remember how to get home. Canary Speech offers the opportunity in a normal annual checkup or biannual checkup to actually test for both mild cognitive impairment and Alzheimer's, and to do so very, very accurately. PTSD and the other things that I've talked about, we have 17 ongoing clinical trials with some of the most prestige and respected clinical centers in the world. Harvard, Beth Israel, Hackensack Meridian, Intermountain Healthcare is working with us to develop and finalize the MS models, multiple sclerosis models. So this is based on science. It's based on clinical review, peer review, and published papers. But in its simplest way, it's non-intrusive. It doesn't interfere with the conversation you're having with your patient. It provides actionable, objective information concerning your patient's welfare and health. Please go on. These are some of the partners that we work with. In the last 10 years, we have been blessed to work with some of the most prestige organizations in the world, and including the National Institutes of Health and Harvard and NYU, Intermountain Healthcare, Samsung, LG Nova. Microsoft is a partner and launched with us in their Dragon Copilot. We're a fully integrated component and product to them. These are some of the papers that we've published, but there are many, many more. Please go on. This is just some of the patents we have been awarded. It's nearly unbelievable to me. The effort to get this job done was started in a bagel shop in Provo. In a conversation between myself and Jeff Adams, I asked Jeff about the field. I asked him, what would you like to do? Not what will we do, but what would you like to do? And he said, I'd always wanted to apply the analysis of speech to human condition and disease. And ultimately, I said to him, then let's do that. He described to me the effort over the last 25 years to accomplish that, which had resulted in exactly 0 products in the field. And during that conversation, I realized you have one of these aha moments once in a while. And I realized that the approach, and it's easy to look backwards, but the approach had been inadequate and simply misguided. Every one of us, every day of our lives, talks to someone and we get an impression of how they're doing. We don't understand exactly how that occurs. But I said to him, you know, my daughter, when my daughter would come home from school and walk across the room, I knew whether she was having a good day or a bad day. I could tell from her gait. And when she turned and I could see her facial expressions, I got more clarity that, yeah, this was a rough day for her. And then I asked the same question that every parent asks of every child, and I got the same answer that every parent gets from every child. I asked, how was your day? And she said, what all of us always hear, it was fine. And I said to Jeff, I don't have the opportunity anymore. My daughter's married and she has her first child at that moment in that bagel shop. I said, and she lives in her own home. Not my best day. I'd still have her living here with me. But when I call her and I don't have these physical cues, and it's irritatingly accurate, I know whether or not my daughter is having a good day or a bad day within the first few moments of chatting with her. And I said to Jeff, how are we doing that? And Jeff said to me, I don't know. But then I said, if we can figure that out, that'll be a very powerful tool in the hand of our clinical teams. Validating what they're already reading, supporting their next step, their next question, how they determine what to do, who they may refer them to, improving healthcare, regardless of where a person lives in the world. Because where they live in the world should not determine what kind of healthcare they're getting. Providing them with objective, actionable, accurate information is key to their care. And that's the basis upon which Canary Speech got started. If you can go next slide. One of the things that in our partnership with Microsoft, one of the things that has just occurred in concert with the Rural Health Funding Program, and I was told this yesterday by Microsoft, and I added a slide today to talk with all of you about it. Microsoft has partnered with Canary Speech along with a couple of other companies and with Starlink. The Rural Fund Initiative does not pay directly for Starlink and high-speed connectivity, but all of us need it to carry out our jobs every day. But this new partnership with Starlink provides that Microsoft and Starlink will provide those services seamlessly within Azure, as long as the product that you're using is on Azure Web Services. And they discounted it 90%. So for rural systems that need high-speed communication and capabilities, if you're utilizing a Microsoft partner running on Azure, Starlink is available within that solution without utilizing the rural health system funding. So all of that put together means that they're pointing this to bring higher quality care to our rural populations, regardless of where they are in the world. And this is specifically to aid in advanced healthcare for those communities which we seek to serve. I think my last slide is next. So we would love to help. We're here in Utah. We were born here. We operate here. We partner with companies here. Anything that Canary Speech can do to advance the quality of care in your facilities, we're interested in helping. And this is some contact information for us. Thank you.
Henry, curiosity question. I kind of mentioned it a couple of times, but is there, so this is voice recognition. Is there any effort to build similar tools that look at facial expressions that can be implemented in like telehealth or other settings like that? Or is it only focused on voice?
We can do that, but many of our models are 95 to 98% accurate. So adding facial recognition is like expecting to get a hole in one every time. Now, I'm not against that, and I'm not a golfer even, but many of the advantages that facial recognition brings are either not needed because voice is such a complex, dense piece of information. It's 1,000 times denser than facial recognition software. Okay. We're working, as I mentioned, with 15 million data elements every 40 seconds. You know, so you're working with such a high degree. We do what is called, what you're mentioning is called multimodal models or multimodal algorithms for analysis. We do use a range of multimodal. We're partnered with Samsung and we're working with Apple right now, where Canary Speech is on those watches. So we add heart rate and steps and sleep time and other elements, temperature, all into our algorithm. If it enhances the accuracy or understanding of a patient's journey through the day, we add those things into the algorithm. We're capable of doing that. And we demoed that or demonstrated that, a few months ago at one of the major healthcare shows, partnered with Samsung.
I want to open up to the group for questions, but I do have a couple other questions as well. If nobody else has any, I can ask mine, but we'll pause for just a second. Henry, if a provider wants to start using Canary Speech as a tool in their clinic, how would they go about getting that set up? Like, how do they access the tool?
So there's a number of partners that we have that deploy it. We can also deploy in their clinic with our own app. So I would suggest they contact Canary Speech. We'll explore what their particular needs are, what they're currently doing. If they're already using Zoom or they're using Teams for healthcare or they're using Teladoc or something, we're already integrated into those products. It's a matter of turning it on in the back office. So they could be using Canary Speech just by turning Canary Speech on. If they're looking to do something over video conferencing, we can always interface into a unique video conferencing system and provide this. One of the things I didn't mention was that Canary Speech has multiple CPT codes that reimburse for what we do. So the hospital would receive insurance reimbursement for doing a behavioral health assessment or doing a cognitive assessment. So they do, in fact, have a positive ROI when they're engaging in the use of Canary Speech's tool.
And what's the cost to get access to the tool if somebody's interested?
It depends to a great deal on what they're doing, but to do an assessment ranges from, below $1 to $2.50, depending on the complexity of the assessment we're doing. If it's a behavioral health assessment, the cost for that assessment is the insurance reimbursement is much higher than that.
Mm-hmm.
So it's a positive ROI.
Okay. Well, that's very helpful information to have as well. So anybody that's interested in exploring using this tool in their clinic or facility, start by reaching out to Canary Speech, and you can help walk them through what that would look like. Right. Okay. So if you're on the call or listening to the recording, we encourage you, if you're interested in exploring this further, to reach out to the info@canaryspeech.com. Definitely, this is a tool that has a lot of potential, and I don't see any downsides if there's a good return on investment to be able to bill for the services. It seems like something I'd really encourage people to look into and consider using in their practices. Can definitely lighten your load a lot as a provider to have that additional tool at your disposal to help you catch these conditions and catch them early.
We appreciate it. Thank you.
Any other questions? Oh, yes, Allie, go ahead.
Yeah, hi Henry. This is really cool. So I'm with the American Cancer Society, and I was just wondering if there's been any conversations about using this technology to support cancer survivors. I mean, I think some of the, fatigue, anxiety, depression are things that we commonly see in this population. So I was just curious if you've explored using it with, in oncology at all.
We have, and we have an ongoing study with an oncology group, one of the best in the world, really. It's out of Texas, and the quality of life issues that you mentioned, anxiety and depression and fatigue, all of those things that we currently measure in a person's voice. So providing individuals with a longitudinal picture of how they're recovering over time. Sometimes having an objective measurement of that is reinforcing for them. How it is. And all of us have had individuals in our lives with chronic illnesses, and sometimes it's just getting the next step off, getting up and being able to measure them across time, even in their own home, using their own phone to do that. Gives them a sense that they're progressing. So those are things that we can do. And we're working formally with this cancer group right now so that we can validate some of these use cases and assumptions, and also understand how it can best fit into their lives.
That's great. Thank you.
Any other questions before we wrap up? I also just want to say, this is a Utah-based company born in Utah. We want to increase the utilization in Utah. It's a shame to have tools like these that aren't being heavily utilized in our own home state when they come from Utah. So I know Henry and his team is really hoping to grow the impact here locally, and we encourage everybody to at least reach out and explore these tools and resources. I mean, this is an evidence-based patented program. We know it works, and we want to see that expand, especially in rural Utah. Go ahead, Henry.
I just saying thank you so much.
Absolutely. Yeah. And same thing, utilize the HEAL resources as well. I hope everybody watching the calls, watching these resources, it's to connect with these resources and utilize them. So we encourage you to reach out, learn about these things, and consider bringing them into your practice. These are tools that help elevate your outcomes for your patients. Thank you for your time today. Our next session is scheduled for June 4th, take place at 12 p.m. noon. We will be hearing from the Global Health Utah undergraduate programs from BYU Nursing. They're going to share some of their stories and outcomes. And we'll also be featuring LungLink, which is an innovative technology that enables patient pulmonary navigation services for chronic lung disease patients. We're also looking for more speakers to fill out our 2026 sessions. We have several more spots still available this fall. If you are interested, you can register to speak with us at our website here on the screen. You can also use the QR code there to register to attend our June session. If you're not already registered to do so, please do so, and we'd love to have you back in June. And we thank everybody for attending today. This recording should be up on the website shortly, but you can explore other programs and recordings from our database there on the website. And we hope you all have a wonderful rest of your day and look forward to seeing everybody in June. Thank you.